All right. Good morning, everyone. Please permit me to stand on existing protocol and especially thank the Cardiocare team for having me on the second time in a row. The GMD says my glasses are on fire. All right, so let's go. Stroke. Okay, no, I can see the screen, but I'm talking about, okay, I should point to the screen. Okay, good, I got it. So, everyone does not need to go abroad for advanced cardiovascular healthcare, that's true. So many more people need to know this. Now, this is the outline I'll be following. It's very easy. What is stroke, why, how to see stroke, and then how we can recognize and evaluate a patient who we think has a stroke, when and how to treat and be fair, and then appropriate care. So what is stroke? It is a clinical syndrome. Now we know what a syndrome is. A syndrome is a constellation of signs and symptoms, 1, 2, 3, and 7 equals XYZ, something like that. So these are the things to note. Number 1, it is sudden of rapidly developing clinical signs. Very important point of history, because when you look at the differentials of stroke for someone that has an intracerebral space occupying lesion, for example, it usually progressive, slowly, as opposed to stroke is sudden. And then even if the patient has a symptom or a sign and it's going to progress, it rapidly progresses. Okay, so that's a fact to always remember. It can be focal or global in the case of coma or disturbance of a cerebral function. All right, and then it lasts for more than 24 hours or leading to death with no apparent cause other than a vascular origin. Very important. So we have other differentials that present like this but differ a little bit, but for stroke it is vascular in origin. It is typically supported by neuropathological, neuroimaging, and clinical evidence for permanent injury. So this is a hybrid of the old and the new definition of stroke. Now, very important that you recognize that it's not just the signs and symptoms. We need neuroimaging to say that actually, yes, there is a stroke. Fine, there's a stroke is a clinical diagnosis, all right? Let's not get that wrong. But when we want to differentiate between ischemic and hemorrhagic, for example, we definitely will be needing neuro imaging for that. And then evidence of permanent injury. Now, let's talk about TIA, transient ischemic stroke. All right, so it's a brief episode of neurological dysfunction or deficit due to focal cerebral or retinal ischemia. This is another concept of stroke and TIA that you must bear in mind, because sometimes the symptom is that the patient may present with is just a transient blood vision that I can't see for a minute or two. All right, but again, when you look at do a neuroimaging, you find that there's an infarct, and that is a stroke. Okay, so sometimes it is just the retina that is involved. It can also be just the spinal cord, and then of course the cerebrum. All right, without any objective evidence of infarction, usually lasting seconds, minutes, with complete recovery. So for TIA, typically that focal neurological deficits last for less than 24 hours. Typically, if it's a true TIA, 30 minutes is gone. All right, but please remember, you have to have focal, there should be no, by the time you do a neuroimaging, particularly an MRI, it will be normal. All right, there are some people that have focal neurological deficit, it disappears, and then you do a CT scan, it is normal, or there's no abnormality. It still cannot tell, we will still not say that that patient did not have a TIA up until the person does what? A brain MRI. And if it is clear, then we say yes, this for a fact is a TIA. What are classification of stroke? All right, so there are 3 basic classification of stroke. I know some people used to say know it as either an infarct or a bleed. Now, it is better said as an ischemic stroke, intracerebral hemorrhage, or a subarachnoid hemorrhage, simply because these are distinct entities. Do you understand? And they are managed differently. So you don't want to clump up intracerebral hemorrhage and subarachnoid hemorrhage. They are both bleeds into one because they present differently, and the way line of management is also different. So it's better to just differentiate them right from the beginning. Of course, you wouldn't fail if you write hemorrhagic and ischemic, but it will be more advanced and better if you say ischemic stroke, hemorrhagic stroke, and then subarachnoid hemorrhage. So this is a broader classification of stroke. What I just want you to pick from this slide is the fact that there are different ways to classify stroke, and one of which is, I think it's better shown here. Okay, let me just go back one bit. Is to know that it's a vascular issue, all right? And from the vascular issue, it can either be venous or arterial. We rarely see venous strokes, but for that 1% that may just show up, you need to know that it is possible. And then the most of what we talk about are the arterial stroke, which can be infarct or hemorrhage, which I already spoke about. And this hemorrhage can either be intraparenchyma or subarachnoid hemorrhage. And then we have the ischemic stroke. Now, for the ischemic stroke, there's a sub-classification of ischemic stroke. Why are we doing all this sub-classification? You know, it's very important to profile patients. When you know and understand where the infarct has occurred or the injury has occurred, and then the severity, you know, the location and all of that. In fact, part of the issue is that sometimes due to the location, if someone, for example, has an infarct, a posterior circulatory stroke, and the person does not have apparently no focal neurological deficit, but of course, if you begin to assess the patient's vision, for example, then you now begin to see, or actually there's actually a focal neurological deficit. And then when you're now talking to the patient, you know, you have had a stroke, and the person gets angry, I've never had a stroke before, and sorry, the MRI or the brain actually shows that you have had one before. So that's the essence of all of this profiling. So it helps you, you know, profile your patients appropriately and communicate properly, and then remove those terms that where patients say things like partial stroke or a minor stroke. There's no such thing. A stroke is a stroke. Then there's the anterior circulation, which can be classified as total anterior or partial anterior, and then the lacunar stroke, that's where the volume or the part of the brain that's been affected are really tiny bits, all right, and then the posterior circulatory stroke. All right, this was what I was looking for, but let's go. Then epidemiology. Now, epidemiology speaks to the burden of stroke. All right, and the burden of stroke is real. First of all, the cardiovascular diseases are the second most common cause of death, with a vast majority of such deaths occurring in low-income countries. All right, and they are projected to be the second leading cause of death by 2030. You know, before now, 2030 feels like or looks like it's far away, but we have it right in front of us. It's 5 years. In 2016, the global burden of disease reported that the worldwide prevalence of cardiovascular disease was 79.6 million. WHO places the global incidence of stroke at 200 cases per 100,000. Just think about that. All right? And then up to 80% of these strokes are actually ischemic. All right? And let me add to that, okay, when I get to risk factors. So what are risk factors? Now, there are two major, groups of risk factors. The non-modifiable group. These are the groups the group of risk factors that you can't really do much about, okay? And they include increasing age, gender, male gender more predisposed to the female gender up until 55 years of age, where the protective influence of estrogen is off, and then race, that's black African descent, for example, more prevalent in that group, and then family history of a stroke and a previous vascular event. So when you're taking a history from a patient who you think has a stroke, it's very important to ask them if they have had a stroke before. They say minor stroke or partial stroke, whatever. You need to get that history. A previous history of myocardial infarction, they may not know that they had myocardial infarction, but they may be able to insinuate. You may be able to insinuate they may have had it if you ask them if they have angina-like chest pain. That's the kind of chest pain that they have with activity. We know that when it progresses, even at rest, they can have chest pain. But just for the generality, you can just ask, do you have a history of chest pain with activity? And then peripheral arterial disease, we saw that in the previous presentation, where the person complains of pain in the calf while walking, for example. Then hereditary diseases, sickle cell, hypercoagulable states, and autoimmune diseases. Then to the modifiable risk factors, things that we can do about it, and gladly 80% of the strokes are actually tied to these modifiable risk factors. So that means, that speaks to the fact that strokes can actually be prevented. So we look at the three trial that we described already: hypertension, diabetes, hyperlipidemia, cigarette smoking, added to the fact that cigarette smoking predisposes the individual to hypertension. It causes chronic inflammation, in fact, that is linked to stroke. All right, and it causes a lot of endothelial injury as well. Then excessive alcohol intake. We know now that there's no safe limit for alcohol, so just even forget that little amount that we used to know before. There's no safe limit, actually. Then next, physical inactivity is a risk factor. Heart diseases like atrial fibrillation and the rest. So I'm going to stop here for want of time, but I've mentioned the major ones. Now, how do patients with stroke prevent? Now, this is the big one. It is either sudden in onset or stepwise progression of symptoms and signs over a few minutes and sometimes even days, because you find that someone just couldn't walk or just had slight one-sided weakness of facial. The next day, the person now couldn't move. That's when they now show up in the hospital. So sometimes it can be stepwise over days. Then there are focal signs. The focal signs relate to the distribution of the affected area, but collateral supplies may cause variation in presentation. All right, I'm going to skip this for want of time, but this just speaks to the subclassification of stroke depending on the areas of circulation. That's the anterior circulation, posterior circulation, and all of that. Now, when the anterior cerebral artery is affected, these are some of the symptoms that the patient may present with. So, disinhibition and speech preservation, all right? Speech impairments, sorry, that should have been. Then the patient may have primitive reflexes. Now, primitive reflexes, if you have ever carried it, most of us must have carried a baby before. If you put your hand in a patient, in the baby's hand, and then the baby just grasps it, and then you carry a baby, and the baby just tends to suckle at the mother's breast. Those are just natural reflexes. Now, you now find that in patients who have had a stroke, anterior circulatory, these primitive reflexes now begin to play out. All right, then they can have impaired judgment, collateral weakness, that's one-sided body weakness of the hands or the legs or the face. Then contralateral cortical sensory deficits. This is very important. So sometimes it's not just weakness or speech. Sometimes it is just abnormal sensation on one side. So it's not always a peripheral neuropathy or cervical degenerative diseases of the spine. That could be the case, but sometimes it's actually a stroke. All right, very important. That is, let me say it clearly, or let me repeat it. That means one-sided abnormal sensation on one side of the body. That's the hand and the leg, for example. All they are feeling is hotness or pins and needles on one side, and it could be a stroke. Gait apraxia, inability to work, and urinary incontinence. Then middle cerebral artery, all right. In this area of supply, they can also have contralateral hemiparesis, that's one-sided weakness, contralateral hyperthesia, that's abnormal sensation, and ipsilateral hemianopsia. That means that when you are assessing when you're asking the patient, to move, one side of the body, and the person does not is not able to move that, does not know that he or she should move that side of the body, okay? Then gaze preference towards the side of the lesion, agnosia, repetitive. Okay, so the patient may also have language deficits. Let me try and make it simple. All right, so we have generally, there are different types of aphasia. So there's the receptive aphasia, and then there's that receptive aphasia where the patient is unable to understand what it is that you're saying. So if you say, how are you today? And the person saying, just begins to say jargons, that's because the person doesn't quite understand what it is that you're saying. So reception is a problem. Then expressive aphasia, where the patient he or she cannot express himself. So you find out that the person, and that's the one that can be very troubling and is associated with depression, because the person understands you perfectly, understands what's going on, but cannot really say what it is he or she wants to say. Then there's neglect, inattention, and extinction of double simultaneous stimulation, and some non-dominant hemisphere lesions. I feel I'm going too far, but when questions arise, I'll take it. Then posterior circulatory cerebral artery stroke. Now, this is also a very important one. Now, the patient, I'll just emphasize on the 4 Ds. The patient may be dizzy, have double vision, that sees to at the double vision, either side by side or one on top of the other, then dysphasia, and then dysarthria. All right, so these are the 4 Ds that the patient can't present with. Then still on the posterior cerebral artery stroke, the 4 Ds are the common ones, but again, vertigo, nystagmus, diplopia, and this phagia, and this arthria, and facial hypothesia, syncopal attack, and ataxia. All right, the features. Now we move on to how hemorrhagic stroke presents. Now, typically, they present with headaches, vomiting, neck stiffness, and then they can have focal weakness or anything that looks like all the other things I've spoken about concerning ischemic stroke. And then, of course, altered sensorium. Now, that does not mean that when it is ischemic stroke, they do not have headaches or they do not have a focal weakness. I mentioned that already. They can also have altered sensorium. Then, for subarachnoid hemorrhage is similar to intracerebral bleed, but the headache is thunderclap. The headache is usually, even if the patient had headaches before, like the patient is a known migraine headache patient, for example, the patient will tell you that this is the worst headache he or she has had in his life or her life, and it is very troubling. The headache most often the times is the most predominant symptom. Then the patient may have vomiting, neck stiffness, photophobia, focal weakness, and altered sensorium, and anything similar to the previous presentations that I mentioned for either ischemic or hemorrhagic stroke. Now, how do we manage stroke? So we first have 5 more. Okay. All right. So we will just follow this algorithm, this ABCD. The first thing is to resuscitate the patient, assess for airway. And I do not like to take this airway for granted, because some people just like to just rattle out ABC. And then when it comes to practicality, what exactly are you doing? So A is making sure that the airway is patent, all right? There's nothing obstructing the airway. And if you have issues with that, you can jaw tilt, okay? And then you can use a suction machine to make sure that the airway is clear, very important. Ensure that the patient is breathing. How do you know the patient is breathing? You see the chest movement, you feel the air moving, and then you can check the pulse, use the pulse oximeter to assess that the patient is actually saturating well. And if it's less than 95, you give supplementary oxygen. Next, you check circulation. You ensure that the patient's blood pressure, that's the pulses and blood pressure, are optimal. And then you secure IV access as well. Then D, you check for any disabilities, and this is where you look for, you seek for your focal neurological deficits. So you quickly do a neurological exam and see if there's a facial deviation, there's weakness on one side, or there's a limb weakness on one side. Those are the major things that you can pick quickly, all right? And then if it's very important to pick fever, you know, if there's fever, and because we need to give antipyretics at that point to take care of the fever, because if there's an infarct or a bleed, it can increase, you know, it can cause an increase in the progression of the infarct or the bleed. Then optimal glucose control is very important. So at that time, when you're checking the pulse and all that and securing the line, you draw blood for random blood sugar and take for other samples as well, other investigations as well. Then this assessment is important, but because of time, I'm going to skip this, but it's very important that you rank the patient, you score the patient, the NIHSS score, to identify which, if it's a mild, moderate, or severe stroke, and then modified ranking score. This measures the level of disability of the patient, and this will help you mark progress as your patient moves. For example, you initially see the patient, the modified ranking score is 5, that means the patient is bedridden. Then after maybe like 3 months, the patient is able to walk with support. That's a score of 4. Now, let's move. Blood pressure management. Now, please remember this. There is permissive hypertension. And the essence of the permissive hypertension is to allow for blood circulation to the penumbra. Now, you have the area of infarct in the center, which is already infected, is gone. But the area around it is salvageable. And for it to be salvageable, it has to continue to receive consistent blood supply. Now, if you crash the blood pressure, it's going to worsen that penumbra. Do you understand? So that is why we allow for permissive hypertension, okay? So what we do in essence is that, just to make it clear, if it is an ischemic stroke, once the blood pressure is over, yes, you can calculate the map and all of that, but just to make it easier and very straightforward, if the blood pressure is greater or equal to 220, 120, then you give antihypertensives immediately, parenteral. And the whole idea is not to crash it, but to reduce it by 15% over 24 hours. What is 15% of 220? So that means what we're trying to do is to take it from 220, for example, to maybe like 200. Our goal is not to crash it, all right? Because we want that area that is salvageable to continue to receive perfusion. Then for hemorrhagic, 180, 120. Then someone may ask a brilliant question. The blood pressure is 220, 120. We're not sure if it's infarct or hemorrhagic. Whichever one it is, once it's 220 and is 120, you can begin to give parenteral antihypertensive already. Do you understand? It's except if it's less than, then we're waiting to do a CT scan to be sure. Then the next point is, okay, so when you have done that, you've done your ABCD, you've picked out your focal neurological deficit, the patient is, quote unquote stable, you now send the patient for a brain CT scan. Now, the imaging of choice is a brain CT scan with contrast. But with plain CT scan without contrast. But of course, if you have the luxury of, the EUCR and all of that, and it's normal, and of course you can do with contrast. But the idea is for time and to be able to do thrombolysis for this patient, you can't do brain CT without contrast. So this picture just shows you the first one. To your left shows an infarct. You can see an infarct on the left hemisphere. It is hypodense. Then the one in the middle is hyperdense. Somewhere in the basal ganglia, you can see that spot that is whitish. All right. Then the last one, you can see lines. So that is subarachnoid hemorrhage. So the CT scan, this is the ideal, in an ideal setting, when the patient comes within 4 to 5 hours, window, and at that point you can't thrombolyze the patient. But from arrival, that's the door to see the doctor, it should be as short as 10 minutes, as much as possible. Then access to neurological expertise. This does not necessarily have to be a neurologist, but someone who is already trained in the stroke team, for example. This person can see and assess quickly that, yes, this is most likely a stroke. We can see the focal neurological deficit. Let's go for a CT scan. And at that time, you've already drawn blood for all the other things that you'll be needing for, like clotting profile and platelet count and all whatnot. And then within 25 minutes of completing the CT scan, you can get an interpretation by 45 minutes. That's cumulative time now, 45 minutes, by the radiologist, who tells you that, yes, this is an infarct, there is no bleed. And then at that time when you have confirmed that, yes, this is an infarct, and then you've gone through the criteria for and against thrombolysis, if the patient qualifies, then you can quickly give the thrombolysis and thrombolyze and send the patient to ICU. All right, so I'm going to skip that. So if you're not doing that, you've already taken blood. You also take blood for EUCR. Very important that you want to know if there are any, because if the patient is hypertensive or diabetic, the patient may also have some form of nephropathy. You want to have that in view when you're managing this patient. Liver function test. You're going to be giving the patient statins if the patient has had an ischemic stroke or has dyslipidemia. So it's important that you check the liver function, because of course we know statins are notorious for affecting the liver at some point. Then fasting blood sugar, we heard that already. You do the trial, not just random blood sugar. Fasting blood sugar 2 hours postprandial HbA1c is not enough for the patient to tell you that, no, the patient is not a known hypertensive or diabetic. You need to screen the patient properly. Then the lipid profile, prothrombin time, INR, HIV screening, toxicology screen, and the rest of them. Of course, you don't do all of that, but the first 5, yes. Then we do other things like echo, ECG, and chest radiography. I'm going to skip that. We don't, because the other ones, like the lumbar puncture, we don't typically do that. It's only if we think it's a subarachnoid hemorrhage, there may be an indication where we would have to do that. So, yes. So with this, I can actually summarize. So look at the top part. I wish I had that pointer that Dr. Iseko was using. Where is it? Okay, please show me how to use it. I should hold it down. Is it my red glasses? Yes, please. Okay, great. All right. So the patient comes, whether unconscious, whatever it is, and then the first thing you notice is that you do your ABC. That's you assess the patient, airway is clear, patient is breathing, circulation, you've taken samples and all of that, and then you've done your primary survey and you can find a focal neurological deficit. You now send the patient for an urgent non-contrast CT scan. When this patient comes back and then is an ischemic stroke, what do you do? I wish I had an insert of those 3 pictures that I had shown you before, and is an ischemic stroke. What do you do? Now, if the patient qualifies for qualifies for thrombolysis in that the patient comes within 4.5 hours, then and then the blood pressure is less than, if the blood pressure is over 185, 110, you control giving IV labetalol, for example, all right, to get it within normal. That's at least 160, 90, for example, to get it down. And then you can thrombolyze the patient. Remember that there's a list of indications and contraindications. So I'm assuming that the patient passes that list. Then we can thrombolyze, and then we keep, before we come here, okay? And just maintaining the blood pressure below 180, 110. Now, if the patient is not a candidate for thrombolysis, which is in most cases we meet such patients, first of all, they've passed the timeline. Once they've passed the timeline, there's no point, going through all the other lists. The major thing to look out is to make sure that the blood pressure management is very important, because we allow for permissive hypertension. We do not want to worsen that area that can be salvaged. You only give antihypertensives if the blood pressure is greater than 220, 110, okay, 120, sorry, and you can give IV labetalol 10 to 20 milligrams over 1 to 2 minutes, and repeat every 15 minutes, a maximum of 300 milligrams. Remember that we only want to reduce it by 15% in the first 24 hours. Okay, then after that we move to the next step, which is we give antiplatelets. We can give 300 milligrams starts if the patient comes in the first 48 hours, all right, and then 150 milligrams daily. Otherwise, you only give 75 milligrams daily, all right. If the patient has had thrombolysis, you have to wait for 48 hours before you start antiplatelets. Then hemorrhagic, whether intraventricular extension. Did I do something? Okay. So one of the things we need to do is, once you see signs of raised intracranial pressure, we co-manage with the neurosurgeons, which will come in, all right, to sort that out. Otherwise, we just focus on controlling the blood pressure, and our target is 140/90. And then, whether it is ischemic stroke or hemorrhagic stroke, early neurorehabilitation as quickly as possible. And remember, they know how to start slow, and go slowly, all right? Start low and go slowly, so that they're not so radical in the neurorehabilitation, which also has speech therapy as well in the neurorehabilitation. Then we go on to secondary prevention and then prevent complications. All right, so I've already said this, okay? Early rehabilitation, it should be multidisciplinary. It's not just the physical therapy. There's speech therapy, there's occupational therapy. There are few, but they are present in Abuja and in Nigeria generally. Then remember fluids. I didn't mention fluids earlier, but please, is also part of the concept of permissive hypertension, or ensuring that the penumbra is well perfused. So we give fluids, IV normal saline, like 1 liter, 8 hourly. However, if the patient has some cardiac compromise, we want to step down on the volume of fluids that we give. Then supportive care, I've spoken about febrile, how we have to give, how we have to control temperature. We have to give antipyretics. Head up, that's the nurse, the head, the position of the head, that it has to be 30 degrees head up to, to help in case there's raised intracranial pressure. It'll help for venous drainage. All right. Nail powers, we also have to assess that there is, for gag reflex, if it is absent, we have to pass an NG tube and make sure there is nail powers. Okay. And then prophylaxis for DVT has to be kept in view. I've spoken about glucose control. I'm going to skip this. I'm going to skip this. I'm going to skip this. So in summary, stroke is a leading cause of disability. The burden of burden of this disability is real. It's not just real to the individual, it's real to the family, especially if the father or the mother, someone who brings in great income to the family has had this stroke. So you can imagine what that whole family will be going through. Then rapid diagnosis and timely intervention is key in the stroke management. Brain is time. So in summary, this is how I like to summarize management of stroke. Resuscitation, that's the ABC that I spoke about, and then you send the patient for a CT scan or a brain imaging, and then recanalization. If the patient qualifies for thrombolysis, then you recanalize. Reperfusion is what I spoke about, where you give IV fluids and manage blood pressure to ensure that it's optimal, so that that area of the penumbra can be salvaged. Then we go to neurorehabilitation. You find that sometimes what happens in a lot of our hospitals is that because they're of the poor, a lot of the physiotherapy department, they can be overworked. So sometimes when you ask for a patient who has just had a stroke to get physiotherapy, they don't even get it until 1, 3 days or 5 days after, and that's sad, So that is something that needs to be looked at, because neurorehabilitation is very important. And of course, there's a place for speech therapy and occupational therapy. Then for secondary prevention, that I did not spend time to look at, but this is very important. So this is where you look at all the risk factors for stroke. Number one, hypertension. If the person is hypertensive, make sure that the person gets good control. Diabetes, if the patient is diabetic, and you have to be sure that the person is not diabetic. Even if the person tells you gives a negative history, screen for diabetes and make sure, all right, because on that presentation may be when that diagnosis will be made. And then we look at lifestyle, issues, alcohol, cigarette smoking, and then exercise, diet and nutrition, and please permit me to mention sleep. Because sometimes some people exercise and then they don't know how to manage stress properly, and then they are not sleeping effectively, because I've found healthy people who have come down with a stroke. When I mean healthy people who exercise, and who look fit, and they're not hypertensive and diabetic. So you need to look at all these other risk factors of stroke, because once a patient has had a stroke, there's a high tendency that they're going to have another one. So just to make sure that they do not have another one, you must and should address this secondary or these risk factors for stroke. I think at that point, you've taken off my slides already, so thank you very much.
Thank you so much, ma'am. Do we have any questions? Quick questions.
Please, I want to ask the place of use of IV monitor and furosemide in stroke management. Also, the furosemide also in the management of the BP aspect. Can we also use furosemide at least to reduce the BP?
All right, thank you very much. So very quickly, so the place of mannitol is for the management of raised intracranial pressure. All right, so how do you know that this patient has raised intracranial pressure? For example, first of all, symptomatically, if the level of consciousness is dropping, all right, then there's evidence of if the patient is vomiting and then blood pressure goes up and the pulse is reduced, that can be a sign that there is raised intracranial pressure. And then if you have the opportunity of doing a fundoscopy and you find papilledema, fine. So those are evidences of raised intracranial pressure, and yes, that's when we use mannitol. And we don't just use mannitol like that. So the way to use the mannitol is you use, for example, 20% mannitol. You give it over IV 20% mannitol over 15 minutes. If you give it longer, it's actually counterproductive. So like 15 minutes, and you give it with IV normal saline because it has a great diuretic effect, and you don't want your patient to come down with AKI. So that's the reason why you give it, and it's also for that reason that you also give furosemide. So we don't give furosemide because of the blood pressure. We give furosemide because we're administering. Some people, in some centers, they don't even bother giving furosemide while they're giving mannitol, but in some centers, yes, while you're giving the mannitol and IV fluid, you give furosemide, you know, and you give it 8 hourly over like 24 hours. So it depends on how the patient is responding. You reassess. If the patient is stable and getting better, fine. Otherwise, you may want to increase it for another 24 hours.
Again, just to re-emphasize, we don't rush down the blood pressure. We have criteria for touching the blood pressure by the height of the blood pressure. And then when we are giving the blood pressure, when we are going to take care of the blood pressure, there are drugs we use. We typically prefer parenteral short-acting drugs that we can control. We talked about that earlier. And furosemide and mannitol is not really for blood pressure, it's for cerebral edema. And by the time we are giving that, we're not using the furosemide to control the blood pressure, we're using it with that one. Just to re-emphasize, the nursing care is perhaps one of the most critical things for the patient that has had a stroke. And whether they will die or not, I don't know whether the study was ever published. There was something done in UCH at the time where they checked the cause of death of almost people from stroke, and most of them was aspiration related, aspiration and pneumonia related. So just to emphasize that what happens in the nursing care afterwards is very, very critical. Okay, but very, very good question. Thank you so much.
Thank you very much. This question is on lifestyle, and you know lifestyle is the cornerstone, whether it's hypertension, whether it's diabetes, and the stroke, as you mentioned. The question of alcohol is not clearly defined. The previous speaker on hypertension said reduce alcohol. The previous speaker on diabetes said reduce alcohol. In your own case, you say don't take alcohol. And the standard recommendation for alcohol for a man and 14 units per week for a woman. When you say reduce, can you quantify it? And now you said stop. Which one do we take?
Follow me. Follow me.
Follow what she has said. Stop. Stop.
So let me even tell you, I'm also a board certified lifestyle medicine physician. What we say is no alcohol. No alcohol, okay? No. Studies have shown, we're not just saying it, studies have shown there's no safe limits.
So no alcohol. Don't start. Don't say that they say red wine. Somebody's here. Somebody's here. Don't say that they say red wine. Don't start. And if you must drink no more than 2 glasses a week, 3 glasses a week, it's fine. But by the time you sit down and say let's cancel bottles, you know that you are canceling life. So 1 glass, 2 glasses, 3 glasses a week, but do not start. Do not encourage. Encourage to stop alcohol, especially once they are having or they are at risk for this. Please stop, stop, stop. Thank you.
Thank you for the presentation. From the medication point of view, talk about aspirin, starting aspirin 300 milligram to continue with 150 milligram daily with clopidogrel 75 milligram. So, clopidogrel 75 milligram. So my question is, many a times you see patients on secondary prophylaxis with aspirin. Some you see them on 75 milligram, some on 150. So please, I need explanation for that. Then for how long will you place a patient on clopidogrel 75 milligram for how long? Then for aspirin as well. Then in patient with hemorrhagic stroke, when do you place them on nimodipine? Thank you.
Thank you. Nice question. So let me take the first. So basically,
please, can we? I'm hearing someone in the hall. Please, let's listen and take notes. We'll be done today. After today, you can gist again. But now let's collect as much stuff.
Okay. So when the patient comes in and you know that the patient has had an ischemic stroke, you should give antiplatelets. Studies have shown that it helps with reperfusion, clearing up the thrombi and all of that. If the patient comes within 48 hours of onset, that's when, up to 48 hours, you can give that 300 milligrams start of aspirin, then subsequently 150 daily. If the person has gone past that timeline, just give 75 milligrams of aspirin. Or if they can't tolerate aspirin, give clopidogrel, 75 milligrams daily. Now, it is that's clopidogrel or aspirin will be part of their secondary prevention or tertiary prevention of stroke. So it will be continuous. All right? You got that. Then the second one is nimodipine. Now, nimodipine is given in the management of subarachnoid hemorrhage. Now, when a patient has had subarachnoid hemorrhage, you remember that picture that has star-like, and remember that their major complaint will be headaches, all right? And you've done a CT scan. Yes, it's a subarachnoid hemorrhage. So apart from controlling the blood pressure, we specifically give nimodipine to prevent rebleeding, because once they have had that bleed, remember that subarachnoid hemorrhage is a bleed, and we want to prevent a bleeding. So studies have shown that we need to give that nimodipine, and we give it for like 21 days. Okay, that has nothing to do with the blood pressure. It is specifically for that. Sometimes we, even in controlling the blood pressure, while we're giving the nimodipine, we're even giving amlodipine as well, you know. But the nimodipine is for that purpose. Thank you.
So remember that the man has had a stroke. So what kind of risk will he be on? High risk, extreme high risk, very high risk. Who remembers? Very high risk. So the LDL target will be what? 55. And then now the ASCVD score is automatically over 30%, Abby. So he will definitely be on that antiplatelet for life. When we're talking about hypertension, we talked about people that you put on aspirin. I would say it's not everybody that you put on aspirin. Only those that their ASCVD scores above 10% or above 20%, and these people now qualify for that.
Okay, so I have two nice questions here. Yes, I need to highlight this very clearly. How long is permissive hypertension allowed? So typically for like 48 hours. So when the patient comes in and has just had a stroke, so within that first 48 hours, you are not touching the blood pressure. You are leaving it as it is. Only if it is an ischemic stroke and it is 220, above 220, 120, then you want to attempt to reduce it strategically over 24 hours by 15% using parenteral antihypertensives. Okay, so 48 hours. So after that 48 hours, you typically commence with what the patient was on before the patient came. And even that, you're not just trying to crash it. You just give it, okay, 10 milligrams of amlodipine, okay, and lisinopril. You just recommend and just watch the patient go on. And remember that the patient is also on IV fluids as well up until that time. So that will also, so typically 48 hours before you recommend the antihypertensives the patient was before he or she came to the hospital. Then please, at what instance do you request for brain MRI and versus CT scan? Yes, nice question as well. So I think you should basically, what you should go with is when a patient comes in, especially if it's an acute stroke, the patient comes in less than 24 hours, as in 4 hours or, within that window, just ask for a brain CT scan. Just avoid any complications. Leave the decision to ask for an MRI to the neurologist or to the stroke team. Do you understand? Just stick to that. Yes, there are times when we would actually prefer to do a brain MRI, especially when there's some confusion. Is this a stroke or not? So leave that to us. But for clarity and rapid response, which is what we are dealing with here, please just go for a CT scan. In fact, a plain one at that. Okay? Thank you.
All right, let me answer the final questions. Who's the next speaker? Get ready. So question one, I see some institutions give both aspirin and clopidogrel. Is that okay? So the setting in which we give dual antiplatelet therapy is typically A, in a patient that is having a STEMI, a heart attack. B, patients that have had a stent in situ. So they typically will take those dual antiplatelet for 6 months to 9 months, sometimes up to a year, typically if they've had many stents. So aspirin and clopidogrel can be given together, especially if the person has had a stent or is having an ongoing heart attack. Coronary, we'll talk about that today. So that is when we use that. In stroke, we typically don't give that because it increases, if you give that together, it increases the chance of conversion. Now, if you've not done a CT scan, do not give aspirin. CT scan and MRI, CT scan neuroimaging is mandatory in the management of stroke. Know that, okay, it's poverty that caused the problem. Don't go and complicate the problem. If they cannot afford a CT scan, please be very careful about just starting it. You might think it's an ischemic stroke and you give that aspirin and the patient will just worsen, because if it's a bleed, the person will just bleed more and get worse. Okay? Very important. Why is aspirin or clopidogrel given to patients that have not had cardiovascular events? Is it right? Remember that we talked about our ASCVD score, right? Who remembers that? And we said calculate it. Calculate, go to this thing, and if it's more than 20%, you can consider it, especially if there's diabetes. What is the role of alteplase in stroke management here in Nigeria? How readily available are surgical interventions? Okay, so she talked about it briefly. I'll just say something and then she can add that as well. Alteplase is a thrombolytic agent. It helps to bust up clots. You will only use it in a stroke that the person got to your hospital, you have had your CT scan done, you have been sure that it is ischemic. And all of that was done in less than 4.5 hours after the first symptom. That the person started feeling like this, I cannot move the hand and leg. Then he got to the hospital. Then he had a CT scan. Then the CT scan was interpreted. And we are sure it's not hemorrhagic. And all of that in 4 hours. Hello? It's possible, Abby?
Yes.
It's possible. It's possible. Ambulances, 911, call a code. Okay? Is it very possible? Sir, what do you think? Is it very possible? They have to go open card, Abby. Then go to pay for the CT scan. Then we have done a number of cases for thrombolysis in Cardiocare. Quite a number, actually. Okay? Now, is alteplase readily available? It's very expensive. It's about, the branded is almost 2 million or 3 million naira for the vial. Tenecteplase is a little bit cheaper, but it's available. So all of that must happen and the money also must be available. So this is where insurance typically will come in. But we have it available in Cardiocare, so you can actually send somebody. I think we are more or less the only institution that has it in Abuja. So we keep it. If anybody needs it, you can come to Cardiocare and pick, so that it does not expire on your hand, since we are a reference center. Okay, then surgical management, how readily available? Surgical intervention is readily available. At least available in Cardiocare, and available in a lot of tertiary institutions, government owned and some private institutions. But it's available in Cardiocare. We've done quite a number of surgical intervention for stroke from EVD. What's EVD again? External ventricular drain. Including drain from the cerebral ventricles, including all those things. So we do that quite a number of times. So it's very available. So healthcare in Nigeria is not that bad. It's just scattered and it's costly and it's difficult for people to pay for it. And the healthcare workers need to come together, learn the education and apply it in an organized manner. I think that's just the main thing. It's not that it's available. Okay? I think I want to identify.
Yes, no, I think you said it well.
Great, thank you so much. We have to end here. We can do stroke for 2 days. I can assure you.